recording. Wonderful. Well, it's great to see everybody. Sorry that it's been a little while since we've had this scheduled, but it's certainly great to have everyone be able to connect again. And this is the last session that we have scheduled under the current registration. So I'll make a new registration link probably later on today, and I'll send it out to everybody so that we can register for the next maybe 6 months or so. I just didn't want to make a super long one and then have something else come up that would then cause me to have to change the times, which we've had to do anyway. So hopefully it'll be easier, but I'll send a new registration link out to everybody. But yeah, so good to see everyone. We'll go ahead and we'll get started. So these articles that I sent out today are obviously old articles, but I
Legacy.
really think
Legacy is the term we use these days. Legacy.
from one legacy, sure. So these legacy articles are are really also just fantastic and are windows in time. And it is amazing to think of what we've understood in the kidneys from just the last 50 years, how much we have uh, been able to understand, and to even predict how much more we're going to understand in the next 50 years is really exciting. So why don't we start with this Homer Smith article? And I hope Homer Smith is a name that everybody knows, but if not, it's one of the reasons I wanted to bring up this article. Homer Smith is really regarded as one of the grandfathers of nephrology, and his works of that he's published, The Kidney, is an amazing book with really fantastic color plates in it that everybody should get. If you don't have it, you can find it used. It's an amazing book that is um, similar to the tone of this manuscript, just really is different compared to other textbooks that you read. The ASN clearly recognizes the role that Homer Smith plays, and they in nephrology, and they annually will present someone the Homer Smith Award. And you really can't be a nephrologist without knowing Homer Smith and being familiar with his work. Really laid the groundwork for the research projects that are done in the Desert Island Physiology Lab. There's so much stuff that can be attributed to Homer Smith, and he attributes a lot of what he understood to some of the predecessors throughout this manuscript as well too. If you haven't read From Fish to Philosopher, it is a really great book that traces the evolution of the kidney, and it's remarkable that Homer Smith could be a really talented uh, physiologist, we would probably refer to him as, although I think he really thought of himself as more of a like a comparative zoologist. And his that From Fish to Philosopher is pretty intense evolutionary history, and just to see the research that he did with hagfish and all these other species, it's remarkable. I have limited talents in one particular field, and I do that reasonably well on my best days. And to see these other people that are amazing in this field and that field and that field, it is inspiring and humbling, certainly at the same time. So I thought that this was a really great article to read, and I hope that the Homer Smith article was enjoyable. Honestly, reading through it, it's a lecture that he presented, but and you can really hear his voice coming through and what he says. So I we can absolutely go through it, and I don't know if Larry, if you have any, if you want to put any other historical emphasis or comments on Homer Smith before we dig into this.
No, that you did a nice job summarizing. I mean, he is the origins of nephrology, and I think that's universally recognized, and nobody would dispute it. The other, I guess the only other thing I would say is it's remarkable looking at the tools that these early investigators had. I mean, the very rudimentary tools that they had, but just by good, careful observations and clever deductive reasoning, they pretty well put together the whole picture, only to be confirmed later on by much more sophisticated techniques.
Yeah.
That would also
Yeah.
be a good journal club sometime, is to talk about the evolution of the ways that kidney function has been studied, from looking at the urine, from clearance studies to micropuncture studies to tubular perfusion to membrane vesicles, and on and on and on. The whole evolution would be a good theme, I think, as well, to give people perspective.
Yeah, I totally agree. And I think that this document is not only historic, but it's just a reminder of physiology, but also just the debates and how things were once regarded and regarded as truth and firmly believed to be fact, only to be completely overturned by further science and research. And I think I hope that we continue to see that, and I certainly know that we will. I think one of the other ways that these studies that are referenced uh, in this paper, as well as the other one, maybe a little bit less so in the other one, but they asked very simple questions. They didn't try to understand everything at once. They tried to understand a very small aspect of kidney function or the movement of sodium in this particular area, and then understood that and then built it out bigger and bigger and bigger until you can complete that grand idea of what the nephron is. And I think as we've gone through some of these sessions, when we talked about um, GFR and the perm selectivity of the glomerular basement membrane and the changes that occur when there's podocyte injury and how those podocytes change the forces of filtration. I mean, none of that existed here. And before I even read those articles just a couple of years ago, that was not even part of my way of thinking about glomerular filtration. So, that was an eye-opening moment to me. And I think we're continuing to advance and refine our models of true kidney physiology, and they're getting better, but they're also refuting some things that have been there previously, which is frustrating, but I think probably even more exciting overall.
JD, I think there's one other theme that comes out in this Homer Smith article, and that is, don't be married to your hypotheses and your ideas. And I think time after time he says, I really didn't believe this, but then the evidence
Right.
came around, and I had to change my thinking. Oh, I didn't really believe this. I'm not sure I'm on board with this, but the evidence is becoming compelling, and that hasn't always been the case in. Certainly not the case in science, but even in our own small world of veterinary nephrology, that has not been the case. And so you need to keep that. I think as a thinking scientist or clinician scientist, you need to keep an open mind and not be so married to your hypotheses or your beliefs that you're not willing to look at evidence.
I completely agree, and I think that is even more important when we look at a lot of the research that's been done in our patients. And you just look at the scale, and you're looking at a research study that's been done in 15 dogs or cats. And that research might never be repeated because someone did a research project in 15 dogs. And that might not be the truth. And if it was repeated, we might see completely different answers. So I think for all of us at all stages of our careers, but certainly those that are actively involved in research, um, yeah, nothing should probably be regarded as truth. and and having that ability to change your mind, even when you've been, maybe adamant. And I will admit to myself certainly being in that position, being very confident about something and then just being proven wrong or understanding it better, and having to recognize that my firm belief ended up maybe being completely false, or not completely false, but improved and then a better understanding of it. So yeah, I think that's also another really good point. And this Homer Smith manuscript really kind of shows his process, and I love some of the comments that he makes along the way in this lecture, and you can really hear that. Well, like that didn't sit well with me. I disagree, and then came across to understand it. Um, Okay, well, why don't we start with we can open the floor. Are there any questions about this manuscript? Are there any areas that people thought were confusing or very kind of enlightening, or they found to be really interesting that we can start talking about before I kind of lead a discussion through it? Certainly, let's open it up first to see what questions or comments people might have.
Well, I would just start by saying if Homer Smith could admit that he was dumbfounded and confused and didn't understand countercurrent multiplication, I join the ranks. That is a very difficult concept. I think one of the hardest that we try to pass on to students is countercurrent multiplication.
Yeah, I agree. It's a very challenging concept, and the way that we teach it to have it make sense, it doesn't necessarily make it a lot easier, because this is a process that's continual, and most times when it's taught, and certainly how I've taught it, you really start talking about the thick ascending loop and the active resorption of solutes, and then what happens thereafter. But clearly, it doesn't begin there. It's an entire process. So it is really confusing, and something obviously that stumped uh, rhenologists, we'll call them, from the British Association. So it is uh, it is a very complex thing, and I think some of the models presented here, even going to pure thermodynamic exchange and how that countercurrent multiplier system works, gives you some insight on how physiology is just mimicked in everything we do, from air conditioning to automobiles. It's pretty amazing. So
Well, I think
any
another point to recognize is when we think about, the countercurrent exchange and developing the interstitial gradient, that's the steady state of the process, not how it starts. And you can disrupt that steady state instantly with something like Lasix or a major fluid bolus. And then it all has to be rebuilt and repaired and restructured in order to achieve its goal. I think that's an interesting point. The other really interesting point is how this system evolved teleologically. That to me, that's entirely incredible. How evolution has created a mechanism like this over the millennia.
Absolutely. And you look at this figure one that's in the manuscript, and this is a primitive nephron, but this primitive nephron exists in many invertebrate species. And again, for those people who haven't read From Fish to Philosopher, Homer Smith teleologically goes through the stages of kidney evolution, from what started as essentially single cells to the primordial nephron, and then how this branch of species had a different change. This branch had a different evolution, and this one was more fitted to the movement of fish to become saltwater fish, or to breathe air, or to finally not have an abundance of water surrounding them at all times. And that understanding and that evaluation is mind blowing, and he presents it really well in that book. So I really recommend you picking up, for anyone who's interested in kidneys. It honestly becomes like a beach read. You can read it on vacation, or it's not just physiology; it's entertainment for sure. So this is the nephron in the figure one that some lower species, for whatever that means, have, and typically in patients in species that don't require such resorption and uh, kind of holding on to water. These are typically seen in patients, species that have an abundance of water, that they're trying to get rid of salts, but they're not dealing with the fact that they have water's a scarcity for them. And it's really fascinating. And then the differences in some species, like seahorses don't have glomeruli. They don't. Like how that evolutionary adaptation developed is just really cool. And I know I certainly just presumed most species had the nephron that we've drawn a million times, that you have Bowman's capsule, and then it clearly makes this dip into Henle's loop, and then the collecting duct runs parallel to it. And even that drawing is not true. We know that it flips and comes back upon itself. But then to me, I never even really thought or investigated whether species would be different. And certainly the variety that we have of nephrons on the planet today is really amazing.
Yeah, and it's also interesting to recognize that the toad bladder and the frog skin are examples or more primitive replications of what has ultimately become the collecting ducts or the collecting tubules. And that's why they're used so often in early physiology to study these things, because the same transporters, the same mechanisms, the same regulation to deal with water reabsorption and sodium reabsorption existed in those membranes as it ultimately evolved into the collecting ducts.
Right. And I love how Homer Smith in this manuscript creates this scenario that one of these rhenologists was crossing the street and struck by a car and goes to the gates of heaven, uh, regardless of any religious affiliation, but was asked to draw the nephron and draws this with absolute confidence and was essentially sent back to Earth to continue to learn, because despite their avid belief that this was fact, it was wrong. But this was the model of the nephron for a long time. And we're talking about experiments that were done in the 40s and the 50s that led to this being appreciated differently, which is really, really remarkable. I did want to note one thing. I think it's later on in this page. They talk about those concentration gradients, and it's in the footnote here. They talk about very low um, urine flow rates and how you'll have a concentration gradient between the minimal amount of urine that's there and just the cellular contents of the urothelium, essentially. And you'll have diffusion of fluid that will occur. And this is exactly what we talk about in those anuric patients that have bladder sweat, where a patient can be anuric, that they have zero GFR. And remember that GFR, we call it glomerular filtration, but we're really talking for solute purposes and the function of elimination of uremic waste. It's glomerular filtration slash secretion slash reabsorption slash finally getting to elimination, right? So if you're not making urine, your GFR is zero, right? An anuric patient has a GFR of zero. You're not filtering and eliminating and excreting anything. But we'll see in some of those patients that are anuric that, yeah, you will have a very, very slow accumulation of fluid in your collection bag. And that may not be urine at all. And we kind of joke around, we call that bladder sweat. And that's probably what it is. And here's a great comment of it with references saying how, yeah, you're going to have some fluid that's going to translocate from those urothelial cells into the bladder, and that could even occur along the ureter as well too. And eventually, that's going to come out into the outside world. What what I always thought was interesting is, and I don't know if anybody has some additional insight, but certainly in people with end stage kidney disease who are receiving chronic dialysis, most of those people are anuric. And because people become anuric quite quickly with reductions in GFR, and many of them are obviously not having to urinate because they're not producing urine. And I was wondering if this bladder sweat ever accumulated in those people to the point where, yes, they did feel that sense, they did have to urinate, and what frequency that might occur with. Would these humans who are anuric essentially be urinating, once a week, once a month, a couple times a year, daily? I speaking to some people who have been on dialysis, they've said, yeah, I don't urinate, but I've never been, never felt comfortable enough to really dig in and ask them some personal questions of, well, what do you mean you never? Like not once a day? Or you're talking about once a week? Because presumably that might accumulate to a great enough concentration that they do in fact go at some point. But I didn't know if anybody had any either personal experience with friends and family members or had spoken to humans who've been on chronic dialysis to give any insight specifically on that. I'll have to ask the next time I'm around family friend who's been on dialysis for I think 40 years. He's had a couple failed kidney transplants, so he's a he's a pro at dialysis. So I'll have to ask him in more detail and report back to everybody. Okay. Again, any questions or any areas that people want to jump into before I just kind of skim through my notes and the comments that I had on this? Open forum for sure. All right. Well, let's just keep rolling through it. I did like some of the comments that that Homer Smith made, and I just highlighted a couple of them in terms of his personal take that he had on things. But I thought this was really interesting that all vertebrates can excrete isotonic or hypotonic urine, but it's only mammals and some bird species that actually concentrate their urine, and that they're compensating for the fact that they don't live in an aqueous environment. And that's a very simple fact, but one that is would not have been something that would have been floating around in my brain until I started reading From Fish to Philosopher, and certainly having it repeat here. So it is very different physiology when you live in water versus you are evolved to live in an arid environment that you are continually struggling to find water. And the kidneys obviously evolved to keep homeostasis and keep the host alive in those water avid and deficient states. So I thought that was just a very interesting fact that's a good reminder.
So JD, I wonder if you can answer the question. There's a popular TV commercial on now advertising an automobile. A little girl sitting in the back seat, and she asks her dad, who's sitting in the front seat, "Dad, do fish drink?"
Oh, that's a good question. Well, I think, I mean, they always have water that runs through their mouth and then out through their gills. But in terms of drinking, um, I don't know. I would imagine throughout the process of ingesting whatever their meal is, they're going to be taking in water as well too. But just like we have this very, very complicated GI tract model, the in the fish and certainly invertebrate GI tracts are very much a different tubular system like this, and there can be very similar comparisons between the a primitive kidney and being a tubular structure and the coelom um, of lizards, of fish, of salamanders. and the coelom and the cloaca essentially has very similar functions, and the kidney is just kind of a specialized form of that. So I guess I would say yes, fish drink, but I'm not going to stand in front of the gates of heaven and proclaim it to be true. I don't know if anybody else has fish experience that they certainly want to say. Okay, so again, going through some of these experiments that were done. So figure two, this is looking at the relative tonicity of the kidney tissue, showing from going to cortex to the papilla, it becomes more concentrated, and this is done via basically like freezing point depression, looking at light being refracted through ice molecules as a way to determine the relative tonicity. And so I think to Larry's point, just the techniques, we're not talking about putting a micro probe osmometer into the interstitium and measuring the tonicity. We're talking about basically measuring light refracted through ice as a relative indicator of the tonicity. And that essentially you change the technique, you're going to have different units on the left side, but you're going to have the same thing that we know, and we recognize that the medulla becomes more concentrated as you go from cortex down towards the papilla. And to a large extent, that's driven by urea and sodium. And that plays a role in how we are evaluating our patients who might have disorders of renal concentration capabilities. So, as part of our PUPD workup, we're going to evaluate the patients for the presence of any hepatobiliary disease that might cause them to have low urea or medullary washout that could accompany that. And Nav actually had a really interesting case. He was doing a water deprivation test on a patient with chronic PUPD and had reduced that patient down to only getting about 90 mils per kg per day of water. The patient was still hydrated, normal electrolytes, then did a AVP trial, and after giving desmopressin, there was no change and there was no response at all. The urine was still dilute. No effect was seen, which would be most suggestive of obviously nephrogenic diabetes insipidus, which is not something we would really expect as a primary disease in this middle-aged dog. So going back to the drawing board and what was missed, and he was looking at all of his diagnostics and saw, well, liver looked okay on ultrasound. Everything was normal in terms of blood work. There was no evidence to suggest liver disease at all. When he rechecked blood work as part of kind of restaging, why is this dog PUPD? At that point, the dog's BUN was low, which it wasn't in the beginning. And then he did bile acids testing and found that the bile acids were abnormally high. And we've seen that as well too, that you know those patients that you have a high suspicion of liver disease, that the liver looks abnormal, they have other symptoms that maybe suggest a portosystemic vascular anomaly, but it's something that I certainly too have been guilty of. The liver looks fine, I'm going to skip doing bile acids testing. And that patient of Knobs essentially had medullary washout because of occult hepatic insufficiency. And it ended up affecting the results of all of the testing that was done for that PUPD patient. And without understanding that, another person might have come to the conclusion that, oh, there's a failure to respond to DDAVP. This patient must have nephrogenic DI. I've found my answer, and where in reality, nephrogenic DI is 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 really rare. I can't say I've ever truly diagnosed a patient with a primary nephrogenic DI. I don't know, Larry, if you have, or how many patients you've had that truly have had a nephrogenic DI that you've observed in clinics.
Yeah, no, you would expect it to be congenital, I would assume, and most commonly, and my memory's not very good, but I don't recall any offhand.
Yeah, I mean, acquired, sure. I mean, that's most causes of PUPD is an acquired nephrogenic DI. So, so going back to this figure, that increase in tonicity as we get from the cortex to the papilla is because of mostly urea and sodium. And urea is going to be absorbed via the UT, the urea transporters 1 and 2 throughout the nephron, and ADH also increases the permeability of those transporters. So urea plays a huge role here, and obviously something that is important when we think about the structure of nephrons. So just another drawing that kind of shows the tonicity, but we think about that with these loops of Henle, and the deeper those loops extend down into the medulla, the more concentrated they'll be able to create that hairpin turn of Henle's loop. But also, as the collecting duct is going down, that's really the site of urine concentration, the final site. Because if we remember, we start off with an isotonic filtrate here. And then as it goes through the proximal tubule, the filtrate remains fairly isotonic. About 2/3 of the salt is reabsorbed in the proximal tubule, but water follows that. So as we get to the descending limb, it's fairly isotonic. Through the ascending limb, and particularly the thick ascending limb, this is where we have active reabsorption of solutes. And in the early stages of the distal tubule, it goes from being a hypotonic solution back to an isotonic solution, and then we finally have solutes that are going to get reabsorbed in that collecting duct. And the collecting duct is really what's handling our water load, but it's the proximal tubule, which is the main determinant site of the sodium load and the sodium excretion. And I think the second paper might highlight that a little bit more.
I thought it was really
Um,
cool, and almost in the first couple of paragraphs where it actually references Henle. Uh,
yeah,
that was kind of cool.
absolutely. Yeah, I think it might have been it's in one of the footnotes where it even talks about like when it was even called Henle's loop, because clearly Henle didn't name it after himself. But yeah, it's in one of these footnotes where it talks about when another physiologist, recognized Henle's model to be correct and then applied it. And again, here's just in figure 5, it's just a model of countercurrent exchange and how that's used in everything from the limbs and extremities of many species to help allow for thermoregulation. And by constricting or dilating each of those vessels can basically serve as a thermostat. By decreasing the blood flow through one of these sites, you can decrease heat exchange. So that's a way to keep your heat balanced in patients that are colder. So like penguins, they have these networks in their feet and in their flippers, hands, a little bit of both. They have them there. And depending on what temperature they're at, there will be altered vasoconstriction or dilation there to allow for heat exchange to occur. And the same principle is occurring, but rather than allowing for a heat exchange, our countercurrent exchange in the nephron is allowing for solutes to be exchanged from that concentration gradient from the filtrate through the tubular epithelial cells and the interstitium. And then remembering that going through the interstitium, you have your vasorecta capillaries, which are allowing for those changes in the interstitium to then facilitate water to be reabsorbed back into the intravascular space.
JD,
So
I think a real important point here, as you're talking about countercurrent exchange, is the tremendous thermodynamic importance of this. And if you were a penguin or you were one of these other circumstances where you had to warm up that blood coming back from your feet actively, it would cause a tremendous expenditure of energy that maybe you couldn't even eat that much to do that. And so that's important. And I would point out that many of you that have a Phoenix dialysis platform, this same mechanism exists in that machine. They actually pass the spent dialysate past the inflow water to warm the inflow water up as it goes into the machine, so it takes less energy to heat your your municipal water up to whatever temperature you set your dialysate for. So we use this very commonly even in our routine activities.
Yeah. And I forget what page it's on, but he makes some really nice comment that um, that this technology essentially could never be patented because it is attributable to physiology.
I
Nobody
love
can
that.
take credit for inventing this because it's evolution that has created it. And I thought that was a really cool comment for sure. Um, he goes into more detail about using more advanced techniques to be able to investigate a countercurrent multiplier, looking at the hydrostatic pressure, comparing that to the oncotic pressure that's there, and showing a model that's essentially Henle's loop that, depending upon the flow rate and the concentration gradients, you'll have at some point along that loop that reversal point, that point where you reach equilibrium and then it shifts. So you can essentially create an infinitely long loop, but you might not use it depending upon the concentration gradients that exist and the rate of flow throughout that nephron. And so our nephrons, our patient's nephrons, are not infinite. There is a fixed length to the loop. So then when we see a reduction in glomerular filtration rate, that's accompanied with an increase in the transit rate, that solutes are flowing faster through that nephron and will potentially go through that countercurrent exchange faster to the point where there's not as much opportunity for that countercurrent exchange to occur. And it's one of the ways that PUPD in itself can lead to medullary washout because there's less opportunity for the reabsorption of sodium, the reabsorption of urea, just because of that fast flow rate. So in a lot of ways, PUPD begets PUPD, and it will create this cycle where the initial injury might have come and gone, but unless new steady state can be achieved, it can lead to a perpetual state of PUPD. Now, if you add some water restriction during that time, whether that's us doing it or whether that's the patient who is vomiting and become volume depleted, then that can reset and allow for difference in that flow, those flow rates and the generation of concentrated urine. So it's not something that's permanently gone, but we clearly don't have these infinitely long nephrons that can handle every single change in tubular flow rate. And for that reason, we see a consequence of PUPD essentially being PUPD, which is an interesting thought puzzle, I think.
Yeah. And another point here, I think, is your ability to tolerate or compensate for different degrees of loss of nephron mass, and is proportional to your concentrating ability. And so, for example, we know that humans are probably the wimpiest uremics. They get uremic symptomatology much sooner than other species, because they don't concentrate their urine. They don't have the capacity, they don't have the nephron structure to concentrate their urine to the same degree as a dog that tolerates uremia better than a human, or a cat that tolerates uremia better than the dog or the human. And if you get, and it's the length of your loop of Henle that's going to determine your capacity to concentrate the urine so that you can excrete a larger amount of solute with a smaller volume of fluid. And that's the game, is to get rid of all of those uremia toxins. And if you can't concentrate your urine, you can't get rid of them in with anything other than an isonatric or isoosmotic urine. And so the more tubular capacity, the more you can concentrate your urine, the better you're going to tolerate decreases in nephron mass.
Right. And it's really interesting if you're not a member of ASN, the American Society of Nephrology, I really recommend everybody become members of it. And they have uh, message boards, which are essentially a better, more organized way of having a communication listserv that doesn't bombard your email with lots and lots of emails every day. But I posted on there about a handful of patients just to get some human nephrology uh, insight on it. And human nephrologists are, number one, amazed that dogs and cats have kidney disease and we do all the things that we do, which is always kind of, I think, embarrassing. But they ask questions like, a dog has a urine specific gravity of 1035. Do they have chronic dehydration? Is that the explanation for it? Not recognizing the the differences in species, and that no, dogs are fine. Cats can have a USG of 1080 and still be hydrated. And it's interesting to see how confused and maybe surprised some of the nephrologists are. Now, granted, most of them are clinical nephrologists. They're not doing research in animal models, but some are and can certainly attest to it. But um, even then, they're probably not using things like the kangaroo rat or golden hamster that has a papilla that extends well into the ureter. I thought that was crazy. I tried to Google this morning some images of the golden hamster kidney if we could see the papilla going into the ureter, but I couldn't find any good images of it. So if anyone happens to see it or comes across a golden hamster on the necropsy floor, I'd love to see a cut cross section of their kidney to see what their pelvis looks like. But
Yeah,
you're
and
right.
that desert rat can concentrate its urine to about 7,000
Yeah.
milliosmoles.
Right.
Compared to a cat that maybe gets to 5,000, and a dog that gets to 3,000, human gets to 1,200, um,
Right.
just because of the structure of their kidney.
Yeah. Which is why the desert rat could survive drinking seawater, and everyone else is going to become dehydrated no matter. The more seawater we drink, the more dehydrated we become. But it would be totally fine for the desert rat, who's evolved to have water very, very sparingly overall. So I pointed out and I highlighted just some areas that just have shown just the difference in our understanding of what is happening in each part of the nephron, and the descending limb of Henle's loop. People really were thinking, well, it has to be permeable to salt, has to be permeable to water, and then that changed. And just the evolution of our understanding, even knowing the general shape, changed over with time with all of these different experiments
JD,
that were
before you go
occurring.
before you go off that page,
Yeah,
I, I'd like to point out there's some absolutely fundamental critical names on this page: Berliner, Levinsky, and Gottschalk. I mean, these are giants in our understanding of veterinary physiology, or not veterinary physiology, but renal physiology. And this manuscript is just filled of. And this is just the past generation of really brilliant people. Most of them are gone now, but Berliner, Levinsky, and Gottschalk, and there will be a few more as you go on here. Just fundamentally giants in terms of understanding the kidney. And so you'll
yeah,
see a lot of references to them. And I think it's valuable to point out the names of these individuals, so that when you see them in the literature or you see them referenced, you have some appreciation for the contributions they made. Certainly, Gottschalk
yeah,
and Berliner were very important in understanding the whole countercurrent regulation, and as well as acid base metabolism in the kidney.
right. And Scribner was referenced, I think, a bit earlier in this manuscript as well too. He did some research on countercurrent multiplication as well too. So I think And that's one of the reasons I think having this manuscript being something that I consider to be essential reading is to recognize the steps that it took to get us to our current state and the amazing people that brought us here, and clearly knowing one of their names is is great, but that doesn't even recognize the whole lab staff that it took for that one person to be able to take the credit for their discoveries. But so many people were involved and still are, obviously, and hence everyone who is present today in the advancement of nephrology. It's important to remember and what people had to go through, and I think it as nephrologists we need to know these names, not because of a reverence, but to understand, as you said, Larry, these were people
Oh,
that took a
I think
model.
I think a reverence is appropriate word. I mean, these were
Yeah,
giants, and I'm fortunate. I've met or I've seen a lot of these people, met a couple of them,
yeah,
uh, and reverence is a good word, I think.
yeah. And I think it's not just to respect them for the sake that someone's told you that we should respect them, but to really go through, as this manuscript is saying, that these are people that were essentially fighting a model that they didn't believe to be true, and did the research and were able to come up with a different understanding that has led to our current appreciation. And that a lot of them fought against the grain in order to do that, and that's not an easy task for anyone. And uh, yeah, so I think really important contributions throughout this whole manuscript.
Let me just add a really quick anecdote. So when I did my graduate work at the University of Pennsylvania, I was in this lab, and there was a great big picture of Richards up on the wall, and so my micropuncture station was right under this picture, and Richards is mentioned in this article as well. And at the time, I really didn't understand who he was and his contributions, but he was there hovering over me every single day as I proceeded to do my humble work.
Amazing. That's amazing. So I love Homer Smith's commentary that he has so much for evidence as he continues to go forward throughout. And this is again just our the model of how we understand this, which is everyone's seen it, and this is some permutation of what we teach when we're explaining countercurrent multiplication and how challenging this is to understand. And I hope that this article really showed that to get to this point, it was a long process, and um, we probably still don't have it 100% correct. That there's probably still some aspects of this that we're still understanding and being able to comprehend to a deeper point. Okay. So I think uh, this we're getting towards the end of the manuscript, and this is where Homer Smith says that he doesn't like the model, that it seems a, an inefficient process to go through the filtration of all of this fluid and solutes, only then to have all this effort that's put towards the reabsorption of all of these solutes and water to go along with it. And um, and he says later, only to acquire water impermeability and active transport for no better reason than Henley's loop has turned a corner, but I suppose I can get used to that as well too. So the concept of just um, we probably still don't understand, or I think we try to anthropomorphize it, and this needs to make sense to me. I need to be able to explain it. If I can tell my mom how the countercurrent multiplier exchange works, then I probably understand it really well. That doesn't mean that I'm 100% comfortable with every aspect of it, but I understand it enough that I can pass it along. And I think that it's amazing to see Homer Smith um, fess up to that as well too.
And I think one of the brilliance aspects of the loop of Henley is the axial heterogeneity that occurs along that tubular structure, even as we stretch it out and think of it that way, but as it bends, and each little segment has its own discrete, unique transport properties that allow the whole structure to work as a unit, as do
Yeah.
other segments of the nephron. But that certainly is one where you have to have these very, very specialized characteristics and features of the whole segment in order to get it to do the job that it's supposed to do.
Right. So I hope that that was interesting. Are there any questions that people had before we move on to the other one? The other one just kind of piggybacks on it, and I think is a nice snapshot in time. But
Oh, they're
before
all
we leave,
they're all
leave
they want us to shut up, I think.
I believe it. Okay, well, let's we have less than 10 minutes left. Let's just move on to this second manuscript by Wardener, which is Controlled Sodium Reabsorption, and this is from 1969. I want everyone to recognize that this is 1969. So obviously the model of the nephron is understood in its current form, that's been accepted, but we're still trying to determine how tubular sodium handling occurs, and we've not been able to identify this. And Wardener is proposing, along with others, that there is some substance that they're naming natriuretic hormone X that allows sodium escape to occur, so that even when we have massive infusions of aldosterone and ADH2 patients, that you can still have natriuresis that will occur. And I and so they talk throughout this, and this manuscript certainly was a little bit tougher in the sense if you're a dog. There were some, they're going through some of these dog experiments, which include connecting two dogs to each other so that changes in the plasma volume or concentration in one may or may not be then reflected in the second patient. But certainly uh, lots of dogs and cats, and obviously countless mice and rats and primates and animals have also been have given their lives for the advancement of that. And I think that that's also something that is very important to recognize, that our models have gotten better, and we likely can do a number of things with computer modeling now that was not able to be done back at that time. But the reason we can model things now is because of those understandings and the knowledge that was gained in a lot of these animal models that are there. And clearly animal models still exist, but computational modeling is to a large extent taking over. And back at the last Renal Week, we had a really interesting lecture, and I'm sure, Larry, you might remember the person's name, where they were able to present essentially a computer model of the nephron that allowed manipulation. That what would happen if we changed the proximal tubule sodium reabsorption from 66% down to 50%? What's going to happen to everything else? And it was a really fascinating model that I think could be a really great tool for using to teach people renal physiology. The way that it was presented, probably it would be a tool that would be at our level, kind of the fellow level, maybe a bit too uh, uh, high level for maybe a student, but doesn't mean that that model couldn't be transitioned in a way that it could be better used for a student. Larry, do you remember that presenter's name? It was a really fascinating model that they had created.
No, I can't remember his name. He wasn't even a physiologist. He was a statistician or something, or a theoretical mathematician at MIT, and he was actually hired by IDEX to develop that model. And it may still, maybe we should push to try to get that into production. But he had no understanding of physiology at all when he started, and we told him to go read Brenner and Rector, and and he did. I mean, the
Wow.
sucker read Brenner and Rector, but really, what allowed him, as you suggested, what allowed him to create the model was all of this early work that indicated what the transport capacities were of each of these nephron segments that were all derived experimentally. Um, and without that information, he would never been able to establish that.
Yeah. I think it'd be really interesting to see if we might be able to get a copy of that model to manipulate. And I think especially for ACV and U training, I think that might be a really great tool to even maybe make it into a website where anybody can go and play around with some of the functions of each of these different nephron segments to see what would occur. And I think it's a really illustrative model. So it would be, I remembered it when I was rereading this article in preparation for today that um, it, I think it could be a really nice teaching tool overall.
Well, let's pursue that. I think we have the networking to see if we can get that established. There also was the ASN gave out a student award or a fellow award one year to a young nephrology fellow who created a similar kind of a model. I think his was just one seg, maybe it was just the proximal tubule or something, but he actually won an award for creating kind of a theoretical model.
Yeah, I think it would be really helpful. So throughout this manuscript, they're really talking about how the proximal tubule is the site of the predominant sodium control. And when we volume expand a patient by giving them lots of saline, that we're going to have an increase in sodium elimination in urine. And that might be despite reducing GFR. So this model, they basically took a balloon in the aorta and blew it up. So it reduced GFR by about 70%. And despite having massively reduced GFR, massively reduced blood flow to the kidneys, you still had, in the state of having volume expansion, natriuresis that would occur. And so they go through all these different scenarios of how you're still having natriuresis that will occur despite having hyperaldosteronisms, despite having a being uh, adrenalectomized, trying to identify where this substance might be coming from. And they talk about infusing hypertonic saline into the brain and trying to identify what organ might be the site of the release of this. And they were able to show, and they talk about the experiments, how you can take the plasma, the blood from a dog or cat that was volume expanded, and then if you administer that to another patient that has normal volume, that they'll have a natriuresis. And that is the support that there's a hormone, that it's not just a local effect, it's not autoregulation within the kidney, that there's something within plasma that can do it. And they looked at all these different organs. They would remove the adrenals, they would remove the kidneys, they would remove the brain from patients to try to see where that might occur. And the take home point of this manuscript is we don't know, but that substance exists. We need to figure out what it is, but it is different and it allows for the sodium to be addressed differently than what we'd expect in patients with hyperaldosteronism, with edema, with DI, with all these different disorders. I think this is a great shot of where the current state of medicine was back in 1969. But we know this, and hopefully, as everyone's reading through this manuscript, you even early on you think, well, you're talking about natriuretic peptide. You're talking about ANP, BMP, this is the molecule that you're talking about. And at this point in 1969, we knew the effects of it. We could show that you could use a a diuretic like hydrochlorothiazide for DI that will actually reduce urine output because of the effects of the proximal tubule. We knew the effects of this substance on what would happen that allows your hyperaldosterone state to not develop edema because of that volume expansion will trigger ANP. ANP is going to cause the natriuresis. So everything was essentially understood except what the piece of the puzzle was. They didn't know the name of it. And they even mentioned that there, at this point in 1969, there was still debate whether it was a hormone or whether it was some other factor or intrinsic property that wasn't understood. And so we're talking about 50 years ago, AMP was discovered and essentially, even at that point, not completely confirmed and believed to be that substance that can cause significant natriuresis and hence diuresis in response to that effective circulating volume. And um, I think this manuscript, to me, my big take home points were just how important that proximal tubule is and how we don't manipulate it very much. There was one comment in the manuscript that um, I was kind of surprised by. Here it is. They talk about furosemide, and they talk about furosemide acting on both the distal and the proximal tubule, and it impairs the proximal tubule's ability to affect salt and water reabsorption. And that is not something that I was familiar with, was not something that I teach at all. And so I went back and I pulled this paper. This is an old Barry Brenner paper. And in that manuscript, they find that furosemide does have some effects in rats in their proximal tubule, but they did not see that occurring in other species. And they specifically say that. So I have not then looked to see to what extent furosemide might act upon the canine and feline proximal tubule, and I don't know if that's the same NAK to chloride transporter or what it might be, but that was something that I had never come across before. I don't know, Larry, if you have any insight
Yeah,
in that.
I actually do. I used to teach a physiology course. I was asked to teach a physiology course for a couple of years, and there's a technique that you can use clearance studies to look at segmental reabsorption, and these studies are done under free water diuresis, and where you give an animal a big load of water so that they're undergoing a free water diuresis, and then changes in that circumstance, changes in urine production actually represent output from the proximal tubule. And so we would do these studies in dogs doing under this free water, and there are ways that you can manipulate it, that you can look at loop function and look at distal tubule function, and you can also look at proximal tubular function. And I was surprised too. But when we gave these animals furosemide, we did see an effect on free water um, uh, uh, on urine production, which would indicate that there was a decrease in proximal sodium reabsorption. Uh, and so I never saw Brenner's article, but this was something that we did experimentally in this physiology class that demonstrated that yes, Lasix does have an effect on the proximal nephron in dogs.
Interesting, really interesting. I'll dig a little bit deeper as well too to see what transporter it might also be affecting, and I can post this Brenner manuscript into the library. I'll do that just a little bit later on today, so that everybody could look at that if you're interested. It's a uh, in pretty detailed manuscript about and pretty heavy in terms of their micropunctures and the studies that they were doing. So I'll be sure to post that. But I thought that this manuscript is very interesting to be able to see all these effects of AMP without knowing the name of AMP, but it also shows how we do have a natriuretic and hence a diuretic hormone in the body. And we have, really kind of just one. We have one main one, and I'm sure I'll be wrong, and there are plenty of others that are we haven't discovered or are isoforms. But the body has evolved to have way more capabilities and mechanisms of water, mostly due to sodium retention. Evolutionarily, we've evolved to move away from water so we can retain it and keep ourselves alive. And we have far fewer evolutionary adaptations to purge the excessive volume that may occur, because that's not something that occurs due to daily life. That's something that's going to occur due to diseases, or in the absence of being administered a lot of fluids. But for a mammal walking around, maybe if they drink too much or something, but that is pretty tightly regulated by thirst. So we don't have as many mechanisms for natriuresis, but it does exist, and it shows over and over again throughout this manuscript how, despite having GFR being abnormal, beside having the distal function of the nephron be normal, be abnormal, it's all controlled by that proximal sodium handling, and that's driven mostly by the hormone ANP to get rid of it. Obviously, angiotensin 2 functions there to stimulate reabsorption of sodium and water. But in terms of a natriuresis and diuresis that can occur even in these states that you might not expect it to be, the big player here is in fact atrial natriuretic peptide, which is our main one. So again, I thought that was a cool way to look at what's known and what's not known at the same time, and just reflecting upon what we understand now. So I hope that these two manuscripts were a little bit of a walk down history, and can highlight just what it took for us to get to where we are now, but also reaffirming our understanding of solute transport, mostly sodium, throughout the nephron. And certainly, I know we're a bit over, but if anybody has questions or comments about this or the first manuscript, please feel free to speak up, and love to um, engage in some additional conversation here if anybody has some aspects that were confusing or just exciting.
JD, there are a lot of interesting things about these two articles, but I think one of the things that's going to stick in my mind is bladder sweat from this
Bladder
conversation. I'd
sweat.
never heard that term before.
Excellent. If nobody takes anything else home, having the term bladder sweat start to get more traction in our community, that's perfect. All
But
righty.
that has a lot of clinical significance. We found in these dogs that you're doing chronic dialysis on, they'll have this bladder sweat, and then that bladder sweat gets infected. And when we're doing long-term dialysis on these animals, we actually have to worry about them getting these horrible urinary tract infections, because you've got this little tiny bit of fluid that just sits there and smolders and gets infected, and then it gets worse and worse and worse. And so that's something to consider when you have these chronic dialysis patients.
Yeah, absolutely. All right, everybody. Well, thanks so much for tuning in. We'll plan on having our next session in a month. Again, look out for emails from me where I will share a new registration link. I'll go ahead and start getting the next few sessions scheduled, and there'll be one registration for the next lump of them. And I'll have a couple articles that I'll send out as well too. Thanks everybody, certainly, for coming and participating, and hope everyone's doing well. For those that will be at ACBM next week, I really look forward to catching up with you. Those that won't, hope to see you all very soon. Certainly take care, and we'll see you guys. Thanks.
And JD, I've forgotten, which hotel are we in?
Thank you.
Thanks everybody.